So Cockcroft-Gault validated an equation to be able to estimate creatinine clearance without actually doing a measured collection of urine. Unfortunately, this was done in only 249 patients, and they were all white males from Canada. So a very homogeneous, limited, non-diverse group of patients. This was also done over 50 years ago during a time when creatinine was not standardized in the lab.
90% of the drug dose choices you're going to make are going to be the same because of the point that was raised, which is we're not trying to dial in 2 mils per minute for making medication decisions. We're trying to dial in a category, which is 20, 30, 40 mils per minute wide. I think perfection sometimes in this is the enemy of good. I think in general, make the move to EGFR creatinine. Most of your decisions are not going to be affected, and those that are probably going to get better and more accurate with this change.
Welcome to Medication Talk, an official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, and the most trusted clinical resources. On this episode, listen in as our expert panel untangles the latest recommendations for using equations to estimate kidney function. You'll hear their insights on when and how to use creatinine, Cystatin C, or both to help safely adjust medication doses in kidney disease. Our guests today are Dr. Erin Barreto, an Associate Professor of Medicine and Pharmacy at Mayo Clinic, and Dr. Tracy Anderson-Haag, a Transplantation Clinical Pharmacy Specialist at Hennepin Healthcare. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log in to your Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editors and clinical pharmacists, Dr. Stephen Small and Sarah Clockers, and start our discussion.
Tracy, can you start us off here by generally telling us about chronic kidney disease?
Chronic kidney disease is generally an issue where we have a problem both structurally and functionally with kidney function. And as pharmacists, we oftentimes think about that as the ability to filter things, filter medications that go through the kidney. But it also has to do with the ability to handle proteins, and there are a lot of neurohormonal effects that can happen with kidney dysfunction as well, impacting other issues like bone and mineral disease and anemia. Usually this needs to be present for at least 3 months, documented in the medical record, and it's generally measured both through lab testing through the blood and also lab testing through the urine.
And I'm glad you mentioned the complications with CKD, since there are many. If kidney function is severe enough, patients may need dialysis to filter waste from their blood, and some may need a kidney transplant if they're eligible. And certain factors can increase a patient's risk for CKD, things such as diabetes, heart failure, and hypertension, which is why proper management for these conditions is key to protect kidney health. Plus, if patients develop CKD, we can determine the severity by the glomerular filtration rate, or GFR. And as Tracy mentioned, GFR affects medications that are cleared through our kidneys. And we usually rely on estimated GFR, or eGFR, using equations that we'll talk about today. And I'm sure a big question a lot of our audience is asking right now is the history behind the Cockcroft-Gault equation and using it for drug dosing, because that's kind of sets the stage for what we'll talk about with new equations. But Tracy, could you give us some of that history to help out our audience?
Yes. So over 50 years ago, when we did not have the science to be able to accurately or correctly measure glomerular filtration rate, which is the best measure of kidney function, we used a proxy, which was creatinine clearance, or basically creatinine that was cleared in the urine. Recognizing that that's an overestimate, because we know serum creatinine is not only filtered, it also undergoes tubular secretion. So creatinine clearance will overestimate our glomerular filtration rate. But this is what we had available. And so Cockcroft-Gault validated an equation to be able to estimate creatinine clearance without actually doing a measured collection of urine. Unfortunately, this was done in only 249 patients, and they were all white males from Canada. So a very homogeneous, limited, non-diverse group of patients. This was also done over 50 years ago during a time when creatinine was not standardized in the lab. And so the creatinine values back in that time were higher than they are now by about 12%. And so we still don't have those samples. We can't go back and validate any of this data with current lab use or a more diverse patient population. And so because all we had was Cockcroft-Gault, this has been used for drug dosing for now 50 years. And we are recognizing the significant limitations that have come about over the course of time and the importance of using newer science and newer technology and newer estimates to be able to better estimate our kidney function for medication-related drug dosing. Another big issue is the weight that you choose to use for Cockcroft-Gault. Because it's not related to body surface area adjustment, you have to select whether you're going to use an actual body weight, an ideal body weight, a lean body weight, an adjusted body weight, a total body weight. And how that is applied is not consistent across pharmacy practice, even across two pharmacists within the same practice necessarily. And that can make a huge difference in your result when you have your weight on the numerator. And if somebody's using an ideal body weight of 50 kilos and the patient is actually 100 kilos, which is very possible, you are going to get twice the number for an eGFR, which probably has nothing to do with their actual kidney function. There are still some practices that artificially inflate that serum creatinine number if it's lower than a certain threshold. That used to be 1 when I first started practicing, when we had the old non-standardized creatinine. And now oftentimes if it's less than 0.8, there'll be rounding that takes place. And there's no scientific basis for that. And it's not applied consistently across practices either. And so I think the variability that you can get with Cockcroft-Gault is grossly expanded compared to what you see with newer eGFR equations that are body surface area, BSA adjusted, using a total body weight and actual patient size, a weight and height at the current time or very recently. And so I think that also makes the variability of the answers that you're going to get between two different pharmacists with Cockcroft-Gault much different than you should be getting the exact same number if you're using an eGFR estimator, BSA adjusted.
Great. And I feel this is a good spot to do a deeper dive into considerations about creatinine since it's used in our eGFR equations. So what are some of creatinine's limitations for estimating kidney function?
Yeah, there's many. So first, this is an endogenous substrate, meaning it has factors that affect it other than kidney function. So it's the terminal byproduct of skeletal muscle catabolism. So anything that affects skeletal muscle mass, to grow skeletal muscle mass because you're bulking up in bodybuilding, or more commonly in our sick patients, to lose skeletal muscle mass through cachexia or inflammation or chronic disease, you can alter your serum creatinine independent of your underlying kidney function. But there are many other factors that can affect serum creatinine, including dietary intake, competing medications at the level of tubular secretion, unstable kidney function that changes the proportion of filtration and kidney and tubular secretion. So there's many factors that affect Cockcroft-Gault that can make it hard to interpret when it comes to especially using it for drug dosing.
Yeah, I think the biggest issue with Cockcroft-Gault, I agree with all you said, but serum creatinine is used in our newer estimating equations that we think are better as well. And so that limitation of the validity of serum creatinine is still a problem with any estimating equation that's using creatinine as a variable. And so Cockcroft-Gault also has creatinine, and so it's impacted by that. But the fact that it hasn't been validated in a broad patient population and that it was, studied and developed in a time when serum creatinines were 12% higher than they are now, the answers that we're getting from that number are really not relevant in the current lab environment with the current serum creatinine that we're getting. And so I think just the inability to validate that in a broader population can limit it.
And with that in mind, why are new CKD-EPI equations recommended to estimate GFR? What are their benefits here?
Yeah, so because the NKF several organizations have come out and said that we need to use race-free, race-agnostic estimating equations for both medication-related decision-making and staging of chronic kidney disease. And so they have given us 3 equations that meet those criteria and have been validated in the most broad and diverse patient population. And that would be the CKD-EPI 2021 creatinine-based estimate, the CKD-EPI 2021 CKD-EPI creatinine cystatin C, or the 2012 CKD-EPI cystatin C, which has never included a race variable. And so we have 3 equations to choose from that meet that race agnostic criteria. Those are going to generally be reported in medical records, and they are generally going to be reported in a standardized format of mils per minute per 1.73 meters squared. And we know that very few people are 1.73 meters squared. I certainly am not at 5'0". And so we know that if somebody is 1.73 meters squared, that in fact is their GFR in mils per minute. But if they're not, their GFR will be higher if they're larger than 1.73 and lower if they're lower than 1.73. And medications don't clear by standardized forms. They clear by body size. And so when we want to use these for medication-related decision-making, we're going to convert them into mils per minute using a BSA adjustment. And so those equations have been shown. There have been pharmacokinetic studies that have demonstrated with several medications that are cleared primarily by the kidney with narrow therapeutic indexes that these equations outperform, as far as accuracy and precision, Cockcroft-Gault or other previous iterations of these CKD-EPI or MDRD or other equations that have not been chosen as our most reliable equations. So we have more accurate measures, and that generally is compared, again, to our gold standard of measured GFR. So these 3 equations, body surface area adjusted, are closer estimates with accuracy to measured GFR.
And as we talk about biomarkers, let's talk about cystatin C, another biomarker we mentioned earlier. Erin, can you tell us more about cystatin C and how it's different from creatinine?
Sure. Cystatin C is a low molecular weight protein produced by all nucleated cells. So it's a little bit different in its origin story than creatinine in the sense that it's not coming from muscle mass, as it were. It is eliminated primarily by glomerular filtration, and then it's reabsorbed into the proximal convoluted tubule and catabolized. So there isn't any systemic reabsorption, nor is there meaningful tubular secretion. So that improves upon one of the known limitations of creatinine, which is the 15%-ish tubular secretion that we tend to see with it, leading to the GFR overestimation. Cystatin C is not a new biomarker, but it might be new to some of the listeners. So it kind of emerged on the scene for GFR analysis in the 80s. But then in 2012, it made its splashy debut in the CKD guidelines as a confirmatory test for CKD. And then since then, it's been heralded as a way to kind of further understand kidney health, particularly when creatinine is less accurate. When we think about the key points about cystatin C that make it similar or different to creatinine. So it can be used for GFR assessment, but it also is biologically active. And so there are factors other than kidney function that affect the serum concentration of cystatin C. So we think of things that affect cell turnover, right? Like I said, that this is related to nucleated cells. So if you have somebody who has uncontrolled, rapidly proliferating malignancy, and their cells are lysing and rapidly turning over, for example, lymphoma, brand new diagnosis of lymphoma, you're going to have a serum concentration of cystatin C that's going to be very high relative to what your actual underlying GFR would be, and it would be not reflective of your GFR. People with uncontrolled hyperthyroidism. It also has a relationship to the inflammatory cascade. So things that cause widespread inflammation, for example, uncontrolled opportunistic infections would be a case, or AIDS, it would have, be a case where you really would have to worry that the cystatin C concentration might be very high, disproportionate to what your underlying true GFR is. There's also a relationship with corticosteroid exposure, where exposure to corticosteroids, particularly high doses of corticosteroids, can lead to increases in cystatin C that have nothing to do with your kidney function. It's not that you can't use it in those circumstances. And in fact, especially if you combine it with creatinine in the combined equation that Dr. Anderson-Haag mentioned, it still probably adds value relative to using either biomarker alone. But you do need to have an understanding of those issues when you contextualize. Obesity, for example, is another factor. There's a higher concentration of cystatin C in adipose tissue, and so that independently can increase it. The other thing to be aware of about cystatin C, so when we think about creatinine, one of the things that we think about is the lag. So if you have a patient who has acute kidney injury or short-term kidney dysfunction over hours to days, which I know isn't the huge focus for today's presentation, but we do need to acknowledge it. If you have a patient who has acute kidney injury, creatinine is like looking through the rearview mirror in that, usually it has a 24 to 48-hour lag from the onset of kidney damage. So by the time you see the creatinine rise, you're already way behind the 8 ball when it comes to trying to make drug decisions. Cystatin C also has a lag, but it's not quite to the same degree. So we think usually more on the 12 to 24-hour side when it comes to the kinetics of it, both on the onset of acute kidney injury and during the recovery. And so it might have a little bit more favorability in that respect. Dr. Anderson-Haag had drawn out the 3 CKD-EPI equations that have been developed to be race agnostic and really heralded as the ones that we should be choosing. When we look at the performance data of those for measured GFR, not talking about drug dosing, what has been shown is that the combined equation with creatinine and cystatin C together has more accurate and more precise than either of the eGFR creatinine or the eGFR cystatin C for prediction of measured GFR. And that's not the same thing as trying to predict drug clearance. That's a different outcome entirely. But nevertheless, I think what we can say is that the combined equation at a population level is the most accurate for prediction of measured GFR. That doesn't mean for your patient in front of you, that's the right choice, but at a population level, that is, because it balances these non-renal factors, these non-kidney factors that affect the activity of either of these biomarkers, and then kind of puts them all into one big soup together and tries to balance them out. So it would be inaccurate to say that eGFR cystatin C is more accurate, consistently more accurate than eGFR creatinine. That's not true. That's not evidence-based. What can be said is that the combined equation is really where it is at the population level.
Now, in practice, though, how do you pick which equation to use? Are there any rules of thumb our audience should be thinking about, if there are any at all?
If we're talking about this in general at the population level, and we're assuming that you don't have cystatin C available to you, which statistically speaking, the majority of places right now don't have it available to them or routinized in their practice. The majority of people are going to have eGFR creatinine. And so the best available choice for eGFR creatinine right now on average and is recommended is the 2021 eGFR creatinine based on CKD-EPI. However, I think we will get to this at some point when we transfer that from CKD diagnosis, which probably isn't the main focus of your audience, to drug dosing. It is important to include the individualized BSA into it so that it is not expressed in the native unit, which is mils per minute per 1.73 meters squared, but rather expressed in mils per minute, which would be more suitable for drug dosing. So that, I think, is kind of the general answer. If you have both creatinine and cystatin C available to you, then I think it's a bit of a debate as to which one you use, and it really depends on your patient factors.
I agree completely that generally speaking, the vast majority of the time, you're going to be using CKD-EPI 2021 creatinine body surface area adjusted. But if there's generally a reason you're getting a cystatin C if you're getting a cystatin C. And then depending on your patient factors, the combined equation oftentimes can make up the difference of limitations from both of those factors and be the most accurate. But in certain patient situations, I always say garbage in, garbage out. If you know your creatinine is severely limited because your patient has no muscle mass, they're completely wasted, any equation that contains creatinine is going to be negatively impacted as far as accuracy. So in that case, the cystatin C alone may be the best estimate. Same thing if you have somebody that's extremely obese, your cystatin C is going to be significantly impacted. Any equation that contains cystatin C may also not be accurate. That said, in many stages of obesity, not severe obesity, but class 1, 2, and 3 obesity, the combined equation, even with that limitation of cystatin C, outperforms either of the other equations. And so I think it just, population-wise, if you're thinking about the number of kidney function estimates that are done by pharmacists in the United States today, I would be willing to guess even 95% or more would be a creatinine-based estimate. We hope that would shift from Cockcroft-Gault to eGFR measures, but very few people have implemented cystatin C, and I think it's very unique situations where we're able to access cystatin C. I think that will change over time, but if you're having to select between equations for a certain patient, it really depends on what the factors are of that patient and why you're deciding to look at a cystatin C in the first place.
I would just add that when it comes to the combined equation for the audience, I would just indicate that while it is not mathematically exactly right, you can think of it kind of as an average of the two. It's not an arithmetic average, but it's kind of an average of the eGFR creatinine and the eGFR cystatin C. So let's say you have, a patient, as was pointed out, who has terrible muscular dystrophy, and their creatinine is that one that never goes above 0.6. Like the best available creatinine that they've got is 0.6. And when their kidneys are torched, it's still 0.6. In those cases, if you use the combined equation, that overestimated GFR from the creatinine is just going to draw up the GFR. It's just going to draw the average-ish up, and it's going to make it look better than it is. That's, I think, why Tracy is pointing out that in those cases, those rare circumstances, that you would probably want to use the single biomarker equation with cystatin C. I also would just like to point out a practical point here, which is like in the electronic health record environment that most of us have available to us, if you have one available in your environment at all to use, most of the time it's important for us to kind of keep it simple. We can't be showing people 10 different equations without context or reason and expecting them to parse, I should use this one in this circumstance, and this one in this circumstance, and this one in this circumstance. It's too difficult. And obviously our EHRs are getting smarter, and so they could, in some contexts, restrict or show things strategically. But in general, you kind of have to pick one for everybody that is broadly available. And what's broadly available is probably going to be the eGFR creatinine. And when you have that, you probably want to use the contemporary equation, and you probably want to make sure that the unit of measure that is used is context appropriate.
I'm glad we're bringing up this BSA adjusted for dosing to get the mils per minute units, which is key for drug dosing. When should I not adjust for body surface area? Are there any circumstances, albeit rare, where that would come into play? Or should pharmacists only be dealing with mil per minute units based on these equations?
If your patient is 1.73 meters squared, you do not have to adjust for body surface area. If they are not 1.73 meters squared, you should be adjusting for body surface area. And I say that a little bit facetiously. If they're close to that, the difference in that adjustment is not going to be huge. So obviously the bigger impact of this is going to be people at extremes of weight or size. And so if you're limited in your time and you can only do so many calculations a day, or your EHR is not able to do those calculations for you, you're going to get the most return on investment for those folks that are farthest away from their ideal body weight or their normal body size. If they're like 1.73 meters squared, 1.73 meters squared is not the average size of an American today. I think it's over 2 for men and about 1.8 something for women in the current era. And so generally speaking, it's going to need to happen for everyone. And really, if you're thinking about drug dosing, that should be in mils per minute. We filter in mils per minute. We clear in mils per minute. Our kidney does not standardize for 1.73 meters squared.
And this is a good time to point out that to make calculations easier, there are online calculators available to you for these equations, because these calculations are complex. I personally wouldn't attempt to do the CKD-EPI equations by hand, and there are online calculators available where you can enter the patient factors, such as creatinine and cystatin C labs, age, sex, and it will generate the answer for you. And some of these calculators, such as the National Kidney Foundation version, can perform the BSA adjustment for you as well if you enter a height and weight. But Be sure to double check that the calculator you're using can do BSA adjustment before using the result for any medication related decisions. And if it doesn't, be prepared to do the BSA adjustment manually. But I'm thinking here, with the calculator options we have, is there anything else we should be thinking about?
I think a nice thing about the online calculators, and Erin had mentioned this too, is that usually you're going to have a creatinine and a cystatin C based answer if you have both of those pieces of information. And then somewhere in the middle will be the combined equation. And whether or not it's higher or lower depends on what your cystatin C and creatinine are. But that will give you, if you have all of those numbers, it gives you a range. It gives you a range, sort of like my worst case scenario would be here, my best case scenario would be here. And sometimes that's the best we can do. And so I really like that those calculators, if you do have both of the variables of creatinine and cystatin C, provide all three of those answers body surface adjusted for you and can kind of give you that idea and range. And you could go ahead and also estimate a Cockcroft-Gault and see where that helps you land in the middle of this thing. And somehow you get, at least a confident idea of 20 to 40 or 40 to 60 to find that dosing window for the medication you're working with, that clinical application.
90% of the drug dose choices you're going to make are going to be the same because of the point that was raised, which is we're not trying to dial in 2 mils per minute for making medication decisions. We're trying to dial in a category, which is 20, 30, 40 mils per minute wide. I think perfection sometimes in this is the enemy of good. I think in general, make the move to EGFR creatinine. Most of your decisions are not going to be affected, and those that are probably going to get better and more accurate with this change.
And how to handle medications where the labeling or like the drug reference states Cockcroft-Gault. Can you just make the jump and just use the EGFR that the EHR is calculating?
So the NKF work group that was representative of a very broad population of people, not just pharmacists, but all healthcare providers were represented, compendia, the FDA, everyone. When you think about how poorly Cockcroft-Gault is actually estimating GFR, remember it's a creatinine clearance estimate. When you think about how poorly that is actually estimating GFR, and we have blindly continued to use that for 50 years, I think that it is not much of an ask to go ahead and shift over when we have good data. There's very good published data on 4 narrow therapeutic index medications that are cleared renally that would tell us that the EGFR is calculated by CKD-EPI, the 3 acceptable race agnostic equations, better mirror or more accurately estimate GFR. And so we are not going to ever see drug companies redo these studies using EGFR. And so we have to start somewhere. It can't be worse than what we've been doing with Cockcroft-Gault for the last, well, at least since creatinine was standardized, which was, mid 2000, 2205, at least by 2011. And so we've had 15 years of using Cockcroft-Gault with serum creatinines that were 12% lower on average and blindly went through that. And so the recommendation is that we go ahead and utilize those nomograms that are put in compendia, whether they were developed through Cockcroft-Gault or MDRD or CKD-EPI that used race or CKD-EPI that was race-based, whether they're reported in mils per minute or mils per minute per 1.73 meters squared. We should be using a BSA-adjusted mils per minute result and utilizing those same tables. Although we do not feel more research is needed to be able to support that practice, we certainly would welcome people being able to compare what they're getting with measured GFRs, especially with medications that we can do therapeutic drug monitoring to continue to show that the choices that we're making are correct. And as we've mentioned before, a lot of this has to also do with clinical management of the patient. You're getting these numbers, you're looking at these tables, but you have to think about the calculation that you're getting, how confident you are in that estimate, and what is the best for the patient if you're going to sort of round up or round down in your dosing choices. What are the pros and cons of those things? So there is never going to be a way that you can just black and white this and look at a chart and make good dosing decisions with any estimate you have. You're always going to have to think about that result and think about how you're applying it.
How should we approach drug dosing in patients on dialysis? Do these equations still apply? Tracy.
No, they do not. So these equations are estimating your kidney function, how your kidney is clearing medications. And when we have dialysis therapy, whether that's peritoneal dialysis, hemodialysis, continuous dialysis, we have a machine that is removing our biomarker, that is lowering our creatinine, that is impacting our cystatin C. And so we cannot estimate kidney function using estimating equations if you've had dialysis. If you're on chronic dialysis, generally we would say your eGFR is less than 10. And most compendia would have a less than 10 section or a specifically hemodialysis section or a peritoneal dialysis section, continuous dialysis section. And so you're going to dose based on that. And you may need to be dosing depending on what their dialysis schedule is, depending on kinetics of different medications. If you have somebody that's having intermittent dialysis, again, that's probably an acute kidney injury situation versus a chronic kidney disease situation. And these estimating equations are assuming a stable creatinine or a stable cystatin C, a stable level of kidney function and chronic disease. And so these equations are not perfect in that setting. Do we use them? Sometimes, but you also have to be thinking about what you're putting in and what's coming out and how accurate that is. If you have a creatinine that's actively falling, you're probably going to be underestimating someone's function if you're using this. If you have a creatinine that's actively rising or no urine output, that's telling you what their kidney function is right there. So again, that clinical scenario. But generally speaking, if someone is using a dialysis machine at some point or has in the recent days, you would not be using these estimating equations. And anyone on chronic dialysis therapy, you would estimate their GFR as less than 10. There are some nuances with residual renal function. You still cannot use these estimations, and safely less than 10 is an appropriate estimate for you.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or Prescriber Insights subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code MT1026 at checkout. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.